It is recording in progress. And just a reminder that on the 21st of March at 10:30, we will be running another community oncology webinar as part of Cardiff University's Spring Online School CPD series. I'll send some more information around that tomorrow to everybody if they want to register. That's enough from me. I'll hand over to the fabulous team. Enjoy.
Great, thank you very much, Charlotte. Well, welcome everybody, and we can't believe that we're actually on the 5th of the final of this current series, and we've been really pleased that we've been able to, with Cardiff University, to put this CPD on, which has been funded by the university, and our mission is to try to keep things as accessible for everybody as possible. This session today really brings some of the key themes that we've been talking about over the last 4 sessions around some of the challenges of communicating with and about oncology issues, sometimes at points when you least are expecting to have those conversations. What would be really helpful, though, would be just to have a quick sounding of actually who's on the call today, allowing for the fact that some people will join us a little bit later. So if you could just tell us what your main role is, that would be really helpful as a first one. That's fantastic. That's fantastic. So we've got a great variety this week, which is absolutely brilliant. Thank you. And the other thing we'd really like to know is where you're joining us from. So whether you're Wales based or whether you're from other parts of the world or other parts of the country. And I think for the moment we're based. That's lovely. Thank you very much indeed. So I'm going to just give a little bit of the context of this session today, and when my slides wake up. This isn't just going to be about communicating about advanced care planning conversations or, in a sense, the palliative care type communications. It's very much around oncology. It's around when you're seeing people for the first time, if you're seeing something that you're not expecting, what can you say? What do you say? And we've actually arranged this one a little bit differently, because what we're going to do is to have a conversation, first of all, about some of the challenges. And then we're going to talk about some of the some top tips of the trade. And if any of you are joining and you've heard me talk about the Cardiff 6-point toolkit, or you've heard my colleagues Nikki Pease or Joe Hayes talk about the Cardiff 6 points toolkit, it's really just a very brief summary and refresher of it, because I think communication skills, we're all busy, we're all balancing many things at the same time. And it's really easy to forget the impact of a word or a phrase or a mannerism. And so it's just really a chance over the next hour just to refresh our thoughts and have us thinking in a bit of a different way. So I'm delighted today to be joined by Elise, as you all know from the previous sessions, but also Ali Shipp, who's a specialty registrar in medical oncology from Velindre, has joined us to give us the kind of perspective from an oncology point of view. So what we're going to do is think about the challenges and think about the opportunity moments, those moments when actually there's an opening for an important conversation, or a conversation that takes somebody into a different direction, and perhaps think about some of the skills that will help. So Elise and Ali, I wonder if I can hand over to you to just get the conversations going. And for everybody joining us today, if you've got questions or thoughts or comments, do please feel free to use the chat. If there are particular questions, then we've also got the question and answer function, which we will be looking in at, and we can address, hopefully, some of the questions and perhaps provide some of the answers or signposting.
Thanks very much, Fiona. And yeah, lovely to have you with us again. I think we just wanted to sort of try and place some of this communication skills into the context of how we're working these days. So I think between Ali and I, we're just going to discuss a couple of scenarios and how you might want to phrase certain things you say to patients, and also maybe a couple of hints and tips of things that perhaps you would like to avoid, based on sort of learning through Macmillan's conversation, communication skills training, and tips and hints that we've learned from other sources along the way. So the first example, I guess, would be a very realistic situation that I find myself in the surgery at the moment, where you might go and see a patient with potential COVID symptoms. And so in our surgery, we'd see them in a hot room, in a room without a computer in, where you just go in and do the clinical examination. You've taken the history over the phone and you go in and take the examination. So you go in wearing PPE, the patient comes in and you examine the chest. And during the course of that examination, perhaps you might spot something on their back, a sort of dark, irregular skin lesion that you know is a potential melanoma, and you perhaps might need to make a further referral about. And I guess what do you do in that situation? It's hard enough in primary care, because you know that patient's expectation is they've come in, they might be worried they've got COVID, they're worried about a whole host of other things, and you're suddenly going to sideswipe them with a comment about something they were completely unaware of. And I think particularly at this time, when we're really not seeing patients that often, I think skin lesions and other subtle signs are really quite easy to miss. I heard Olwyn Williams, the RCP vice chair, speak the other day, and she was saying she'd seen her GP, and it's the first time she'd been touched, examined by anyone, seen anyone physically to contact her except her family in the house in the last year. And I guess, that important thing that we do when we examine patients is so rare these days, that we have physical contact with anyone. And so what happens when you find something that you're not expecting? In the situation that you're in the hot room, you don't have access to the computer record to know whether there's a melanoma that was known on the back, to know that whether they've had it previously, or whether this is something they were referred for last week. So it's always important to try and understand what the patient knows about it, first of all, check the patient's understanding. An icebreaker, something along the lines of, well, there is something on your back, I'm not sure you're aware, but has anyone seen this before? Something just to, raise the patient's interest. I think when you're going to be referring that, it is important to explain to the patient what you need to do and what will happen next, and allow them some time to pause and to understand what you're saying. You must explain to them that it is an urgent suspected cancer referral, because unfortunately, cancer referrals, that they're not as high as they should be. That's partly why we're doing this series, but patients are not attending their appointments because they don't realise the significance either. So please do tell them. And in fact, we are producing a leaflet, a leaflet you can give them to explain what the process is and why it should be fast, and what to do if they haven't heard within a certain window. I think the other things you can do in this situation is allow some certainty. There are some things you can tell them that you are sure of. You can tell them when you're next in the surgery if they'd like to discuss it, or what will happen next, what to do if they haven't heard next. They can contact you back if you haven't heard within 2 or 4 weeks, whatever you would see fit in your service. The other thing, whilst you've got the patient in the room, even if it's not a skin lesion that you've spotted, would be to do things that we don't have a chance to do very often, things like weighing the patient. We heard in the bowel talk the other day that, weight loss is a referral criteria for bowel cancer, and if we're not seeing them or noticing weight loss, these things will get missed. Our dermatologist colleague, Dr. Abbott, advised looking at the back of male patients when you have the chance, and the legs of women. So please do try and take those opportunities to, record the blood pressure, look for those vital clues, and then to code it and make sure it's there in your notes so other colleagues, if it's not you that sees them in the future. And I guess just to be mindful of what you say and how you close the consultation, which I know is something that Fiona is very passionate about. But, things like "don't worry, it'll be okay," little platitudes like that, which you feel as a human you want to say, perhaps it isn't necessarily the right thing, because the patient will worry. And so therefore say something that sort of reflects that. I can understand that you're worried. I would be worried in the same situation, but that's why we need to do these things as an urgent measure. And that's why we'll be supporting you and looking into it. Ali, do you want to go through how?
Oh, sorry.
Sorry, no, I was just going to say what happens when they arrive with you. So when they end up, being seen by the specialist and then end up, for chemotherapy, or, as you were saying yesterday, really, I guess, by the time they've got to you, they kind of bad news has been broken in part, hasn't it? They're expecting to.
So it's a very different situation than what you were just talking about. But I think something that I wanted to talk about a little bit, probably because it's happening on the other side, is patients who are currently on treatment for their cancer. And much like you, we've been trying to reduce footfall in our hospitals. We have been doing less face-to-face work. So people who are on treatment have been having virtual reviews as well as face-to-face reviews. And people have been afraid to come to hospital. lots of those things are similar, but thinking about patients who are on treatment, something that we've perhaps noticed during our on-calls is we've been having a few more calls for people attending for treatment and concerns about they don't really look so well, and are they fit for their treatment? And that's made us think about the way that we're working. We've always known that patients quite often have massive fears about, if they tell us they're not feeling well, we're going to stop their treatment, and they really want their treatment. We've always known that, and there's a generation of patients also that don't want to upset us, since we've worked so hard to give them their treatment. Those issues have always been in oncology outpatients, but some subtle changes with COVID communication. Previously, patients might have attended with a relative, and quite often you'd say to the patient, oh, well, how are things? The patient says, oh, yes, I'm doing well, thank you, yes, I'm all right. And then the relative's quite often sitting behind them going, no, and looking really worried. We haven't had that luxury of relatives in clinic, which is hard for patients when relatives are advocates for them. Arguably, for some patients, it means they've got more of a chance of getting a word in edgewise. And for the relatives as well, that's really difficult. We know, and I think you probably talked about in previous sessions, people's recall of a consultation is pretty limited. And so the patient recalling consultation, they're referring back to their relative. A lot can get lost in translation. I'm really sorry, there's a bit of drilling going on here. And how do you navigate that? And how do we kind of balance keeping patients safe from a COVID point of view and adequately assessing them to make sure they are fit for their treatment? So there's an awful lot of kind of stuff to unpack there for the patients who are on treatment. In terms of involving relatives, there are options if patients want that. So if patients coming face to face, we can offer for the relative to join virtually if they'd like that, and that's something that we've done. Some patients want to take notes or record, and again, we've done that. So those are there as options for kind of opening up those opportunities. I think acknowledging that it goes on, and people do have different agendas and motivations is useful, and really probing and doing a good assessment of what they're actually up to. So, how was it getting up and coming out to that appointment? Is today a good day or a bad day? Really kind of delving into that. And if you're worried that what they're saying doesn't fit with what you're seeing, kind of probing into that. And that is more difficult virtually. And I guess for us, thinking about, well, do we alternate? Do we do a face-to-face and then a virtual, and then a face-to-face and then a virtual? Do we do things that way? Lots of things there. I'm sorry. But that's something that we're still getting to grips with, is in finding that balance. I think probably a lot of the things you talked about in previous sessions, just asking a bit of open questions and trying to find those opportunity moments can be really valuable. But again, just that is a bit more difficult when we're using virtual means of communication. Difficult to pick up those imperceptible things during silence. And I know Fiona is really passionate about kind of picking up on those kind of the end of the silence and how the silence ends. And that is more tricky to navigate virtually. If we're worried, saying what we're worried about. So lots of challenges that have always been there, but that have probably been highlighted during COVID, possibly some opportunities as well, for kind of learning from thinking about it. And I think talking about that kind of leads us on to kind of the breaking bad news things. And Elise and I were talking last night about the fact that we're reducing footfall means that when we do call people and ask them to come in, they immediately panic. And I think that's probably true is certainly true in secondary care, but it's probably the case in primary care too, is it, Elise?
Yeah, absolutely. As you're saying, like, you know, it's probably true even before COVID, but if we get a scan result in with something to worry about, it often comes through as an urgent on a fax line. I mean, I'm not sure why we still fax, but that's another story. And it's put in front of the on-call doctor on the day, and they may have only had the CT scan the day before. So the patient, if you ring them the following day, that phone call, when you said, oh, your scan results back, for a lot of patients, particularly informed patients, to know someone's ringing the day after a scan, that is a sort of warning shot, isn't it, for want of a better word? That's a worry that someone's trying to get hold of them immediately after having a scan, because it probably isn't good news in that situation, as ringing a relative and asking them to attend the ward is not currently good news in Velindre.
Yes, definitely. So it's been all over the media that you can only possibly visit your relative if it's maternity, paediatrics or end of life. And most people will usually have clocked that it isn't maternity or paediatrics. And the truth is, that's not quite everything, but often if we are referring someone to come in, it is because there are big conversations to have, and there isn't really a way around that. People have clocked it. How have you found kind of opening up the conversation and starting things, Elise? What kind of tips and tricks have you been using?
I think, as you rightly pointed out as well, I mean, the first and very important one is, are you driving, isn't it? You know, where are you currently? Because if you're behind the wheel, and actually often you can hear that, and something they'll say, no, I'm on speakerphone, the kids are in the back, it's fine. Be like, okay, well, you know, you actually need to just establish a situation that the person at the other end of the phone finds themselves in. And often it's, I'm just dashing into the office toilet, or, you know, just moving to somewhere a bit quiet. That probably isn't the best place to try and have the further discussion. So, I mean, I don't think that, you know, that there isn't, and you certainly shouldn't be advised to kind of sugarcoat it either. It's not the case that you'd be ringing to say, oh, no, don't worry, I can speak to you in a couple of weeks. You know, there is something urgent you'd like to discuss and something that you would like to have a conversation with, but it's just ensuring the patient receiving that news is in a safe place and supported by someone. And they actually don't need to receive it right there and then, but know that you'd like to speak to them. So do you think you might be able to find the time to pop up to the surgery later on in the day? Or would you like me to call you back at a time that's convenient with you, and arranging a time that sort of suits them? Because fundamentally you are ringing them out the blue with this news, aren't you? And I realise that's less the case when you're asking them to come up, but it may be that you're saying, you know, come up to Velindre for 4:30 or for, you know, 3 o'clock rather than right now in some situations.
Yeah, and we do also phone with, you know, clots on scans and blood results and things, but you're right, they weren't expecting it. We're putting ourselves into their world. They were just doing their shopping, and yeah, finding out who's with them and whether that's okay, because then maybe their husband is with them, but maybe they didn't want their husband to be with them. Things like that.
Absolutely. And, you know, if you ask someone, you know, would you like to come up to the surgeon and bring a relative with you? You know, again, most people would think that's not going to be great news. But, you know, from the conversations we've had within our practice staff, some patients would prefer to have that conversation in their front room, in their living room with, you know, on speakerphone with relatives around them so other people can hear it too. So it is trying to understand what works best for them. And I suppose if we could try and head that up, that would be even better, isn't it? Look, we're sending you for a scan because we are worried. If we do get the scan result back quickly, how would you like to have that discussion? If you have the opportunity to kind of, you know, prepare for that scenario, that would be really helpful. I think sorry, I just because I think you've touched it, but you know, that use of silence is important, because whilst you're sitting there trying to tell them something and it goes very quiet, in your own head you might be starting to panic and think, I don't quite know how to come out of this, but in their head it's like white noise, isn't it? Everything's going around, they can't quite make head and tail it. Very, very busy. So they don't hear the silence as much as you do you? So you need to give them that space just to take it in. I think what you do need to do, as we've said before, is offer, you know, what you can be certain of. So if I've rung someone at 11:30 in the morning to say there's a scan result coming at 2, tell them at 2, you know, say, look, I appreciate this is a really huge amount of information to take on board. Would you mind if I rang you when you got home? You know, if I spoke to you about 4:30, 5 o'clock before I finish work this evening, you know, offer that touch points that you know that you can be there for them and that you can offer them support. Try and avoid saying things like, I know what you're going through, because we really don't. Even if you or your loved one has had the same diagnosis, you don't know what the husband is going through at home, or the children, or anyone else. So it isn't something we can relate to. You can say things like, this is clearly a very difficult time, and I can feel that this is very frightening and upsetting for you. To acknowledge that sort of emotion, but not to say that actually you are in the same place, because none of us are in the same situation.
Or even if you've had a very similar situation, you're still not, because you've never been them. So
And what it resonates with them as well, isn't it? Because even for some things that you think are, you know, less significant in terms of a diagnosis, if their relative died of that same diagnosis, or, you know, it has repercussions, we just don't know, do we?
Yeah, and the other thing that we spoke about briefly is kind of once you've made that phone call, quite often people are kind of like, well, clearly this is bad news. Tell me now, please tell me now.
Yeah.
And then that's all they're going to think about. And I think sometimes I have ended up doing that and apologising because it's not the format that perhaps we would have chosen. But as you say, that kind of that valuable, you know, when you finish up, you know, it's been a lot of information. What are you going to do now? And that option for checking back in, I think, can be really valuable.
Yeah, and we have done that in the practice in the last couple of weeks as well. Someone who encourage you just to tell them, they just want to know this is fine with them. They'd rather not have to wait another couple of hours so they can come up, just tell them. And it is just trying to make sure that you have put some safety nets in so that you know when you're going to contact them next, how they can ask for help. You know, signposting to further advice as well is really useful. I'm just very conscious of time, Ali, as well. I'm just thinking Fiona's probably keen to get onto her sort of 6-point toolkit, but I guess the other part of sort of having these difficult conversations is talking about kind of advanced care planning and you know, what happens next scenario. And that one in general practice certainly sneaks up on you when you least and probably most don't, when you're least expecting it, and most don't want it. So, you know, you've had a really good consultation, perhaps face to face, you know, for some sort of review after being in hospital, check the blood pressure, feel like it's all gone smoothly. 10 minutes, they're going to be leaving shortly. You're wearing PPE, it's hot, sweaty, and then they go, oh, doc, you know, I don't want you sending me to that MAU again. If you've been, you know, to the local hospital recently, it's like a war zone in there. I don't want to be going there. Couldn't have visitors. Really don't want that again. And for me personally, and probably a lot of my colleagues, that's a big kind of intake of breath, kind of pause, take stock moment, because that's a whole new conversation which you hadn't allowed into that sort of consultation time, and really needs to be given the value that it deserves. And, you know, I think it's acknowledging that and go, well, you know, that's a, you know, reflect it back. That's a powerful thing you've just said, you know, Mrs. Jones, Mr. Jones, is that really what you think? You know, please tell me a bit about what you're feeling, you know, acknowledge what they're feeling, and also thank them for the trust that they're sharing in you, that they feel they can say that. And in the most cases, I think actually patients don't mean it. And they'll quite often say, well, obviously, if it was a life-threatening situation, I'd go back in, but I don't really want to go back in if I don't have to. And I guess it's knowing what to do with that information. So certainly there's a lot of resources about advanced care planning. You know, I work in Cardiff, wherever you work, you know, in your service, there will be resources. I know with the end of life facilitators in Wales, we've put them available to you. So in Cardiff and Vale Clinical Portal, you can go through to the palliative care pages and download the ACP paperwork for those with capacity and for those without, and also the guidelines on how to fill it in. So quite often, even if I don't have time in that consultation, I know there's a QA test. So look, you know, this is really important. You know, we can't rush through this. We must talk about it. How about I send you some information in the post and you have a look through in your own time, and then we make a consultation where we fill in the paperwork and talk through what's really important to you. And I think for those of you who've heard Mark Talbot speak, you know, the key is what matters most to you. Because I think when people hear advanced care planning, they think, oh, doctor's writing me off, I'm dying. And that's not it at all, is it? We're just trying to say, and for all of us, we should have one. Actually, in the event of a life-changing significant event, would I want a tracheostomy? Would I want to be artificially fed? You know, all those key points, we should all be able